I think this is something I thought was interesting to share with the group, as perhaps not a terribly uncommon scenario of interest in the overlap area. So this was a 23-year-old woman with a history of ulcerative colitis, and she presented to us with these erythematous scaly plaques in the scalp, behind the ears, as well as the palms and soles. She had no known prior history of psoriasis. Again, has a UC history that's been well controlled on infliximab for the past 3 years. But however, there is a family history of psoriasis, and you can see an example of the kind of eruption here on the palms. And let me skip ahead. I think we have a question here. So, which statement is true about this condition? It is unlikely anti-TNF induced or so-called paradoxical psoriasis because it started 3 years after the initiation of infliximab. Palms and soles are not typically affected in TNF-induced psoriasis. Skin biopsy of this eruption may demonstrate features of sort of a mixed picture of both eczema and psoriasis. That would be described as spongiosis and psoriasiform dermatitis with eosinophils. Stopping infliximab, that we should consider stopping infliximab immediately to avoid erythrodermic or very severe psoriasis. So the question is, which is true about this condition? I'm just going to take a look at our ARS results here, and we have a very savvy group on today. It looks like everyone's chosen C, which is that a skin biopsy may show features of both sort of an overlap of psoriasis meets eczema with the eosinophils. So let's take a look at this in a little more detail. I know we have not too much time left, but this psoriasis, TNF-induced psoriasis or paradoxical psoriasis, is certainly an interesting phenomenon. It's not uncommon, in particular among IBD patients receiving anti-TNF therapy. This is one study that looked at about 150 cases, the majority of which had Crohn's over ulcerative colitis. Some percentage, about 11-12%, had a family history and or personal history of psoriasis to begin with. What's interesting is the median time this is very different than we would see with a hypersensitivity skin eruption. Right? This can happen many months or even years into treatment. It's certainly been reported as long as 10 years after therapy, initiation of therapy, and it's common, and it certainly can happen with any anti-TNF therapy. It seems to be a bit more common with infliximab than some of our other anti-TNF agents. This is a discussion about how we should approach these patients. The couple take-home messages are, in general, we can, if it's more mild to moderate disease, we can certainly try to treat through it. I'll show you in a moment an algorithm that we put together thinking about how to approach this condition. Interestingly, very few patients, when switched to a second anti-TNF, improve. So it's not. It really seems to be a class effect, I think, is the take-home message. And not a small percentage in this series, up to 43% of patients had to stop their anti-TNF because of the skin eruption. And it can really show up in many different areas. It can look like classic plaque disease. It can take a more pustular appearance. It can involve palmoplantar surfaces. You'll see here that a large number, about 42%, had palmoplantar involvement. Many also, like our plaque disease patients, can have scalp involvement or other areas involved. This is a patient that I had with rheumatoid arthritis who started anti-TNF therapy and developed this palmoplantar pustular variant almost a year into her therapy. And interestingly, while it can take many different forms, on histopathology of one of these eruptions where it shows both spongiosis, which you might expect more with an eczema type variant, as well as concurrent psoriasis changes in eosinophils, should make you really think about anti-TNF induced disease. In fact, at our center now, if we send in a history like this and it comes back with spongiatic psoriasiform dermatitis with eosinophils, our dermatopathologist will quickly put in the differential, consider TNF-induced psoriasis, which is very interesting. This may be its own entity, in fact, and again, just in the interest of time, I'll share that if you do staining for type 1 interferon expression, which is shown by MXA expression in skin, psoriasis itself does not show a lot of MXA staining, whereas the psoriasiform TNF-induced eruption shows quite a bit of type 1 interferon staining, more akin to what we might see with certain other conditions like lichen planus, lupus, and other things. So it may mechanistically have something to do with driving type 1 interferon expression in the skin. We've actually, to this point, just as an anecdote, we've had some success utilizing JAK inhibitors, and I have a feeling that the drug that Philip and I mentioned earlier, deucravacitinib, may well treat this condition quite well because it blocks both type 1 interferons as well as some of the cytokines involved in skin psoriasis. So how do we treat this in the end? We can attempt to treat through. Otherwise, if for more severe disease, we may consider switching to another class. And so again, if it's mild disease, we certainly may think about, and if the patient's benefiting from their TNF inhibitor, we may certainly think about treating with topical steroids, UV therapy, adding methotrexate, adding acitretin. We published a paper considering use of topical or systemic dapsone for more pustular disease. On the flip side, if the patient has more severe disease, or perhaps they would benefit from switching to another class for other reasons, we increasingly have a large number of other agents to turn to. In the case of psoriatic arthritis, to our theme today, certainly switching to IL-17 inhibitors, 12/23, 23 inhibitors, or JAK inhibitors as appropriate would be, one way to go. In the IBD space, we've had good success switching to, in particular, IL-12/23 inhibition in this context. But we have a number of other agents in that space, integrin inhibition, and others to think about in patients where TNF-induced psoriasis is a particular challenge. So I think with that, I'll turn it back to Philip to give us our final thank you and some wrap-up words.
Wow, these have been some terrific cases. I've learned from this, and I hope that the case that I represented with gout and axial PsA and so forth, that patient, on the one hand, it's complex, but it's exactly the kind of case that is so appreciated by rheumatologists to work through the algorithmic thinking that we are used to doing in our brains to come to correct conclusions and correct treatment approaches. So we want to really thank you very much for participating in tonight's program, where we've gone the arc of talking about psoriatic arthritis from its pathogenesis to its clinical presentation to some of the current treatment recommendations, and then illustrating all that with cases. And I want to especially appreciate Joe as my co-presenter this evening. Terrific, Joe. Really enjoyed it very much.
Thank you. Thanks for the invitation, and always a pleasure, Philip. Thank you.
Yes. All right. So have a good evening.